Good afternoon, everybody. We are presenting a two-part video for IVF stimulation, personalized, optimized, and simplified. In the first part, I will describe the decision support tool for optimizing and personalizing treatment, dosage treatment for IVF, and Dr. Naina Patel then will present follow-up with her experience with OPT IVF. Thank you. Good afternoon, everybody. I am Urmila. My name is Urmila Divekar, and I am working in United States. I am going to present to you a different approach to IVF stimulation, which is personalized, optimized, and simplified. So I will share my presentation now with you. And it is, as I said, IVF stimulation, personalized, optimized, and simplified. I have three hats. I have a non-profit institute, Vishwamitra Research Institute, which I started in United States for doing multidisciplinary research. I am also professor at University of Illinois at Chicago, and now I have a profit-oriented organization called Stochastic Research Technologies. And if you need more information about Opt-IVF or more information, technical information, you can always write to me at urmila@vri-custom.org, or you can send email to optivf@stochastic-research.com. So question is that I have a PhD in chemical engineering, and you must be wondering, what am I doing in a gynecology IVF conference? The reason is being I worked on in vitro fertilization research for last 10 years because I was a patient of IVF, conducted number of cycles both in United States and in India, had a lot of complications, including going admitted to emergency room and things like that. I also noticed that the drug dosage which was used for me in United States were much higher than in India because of cost consideration, but outcomes were not different. That's why I decided to work on this topic and essentially come here to show you what we have done so far. So you all know that IVF involves 4 steps. The first step is the superovulation step, where egg production is stimulated by hormone therapy. Essentially, instead of getting one mature egg, you want to get as many mature eggs as possible so that they can be fertilized outside and put it back. And each step they lose some of the follicles, so that's why you need more than one follicle, multiple follicles. So it's a multiple ovulation process, and this is the most expensive step in IVF. It also, success of IVF depends on how many embryos and what kind of embryos you get. So superovulation is a very important step. What did we do? We actually thought about, when I was thinking about it, I thought how I can actually model this process. What is happening in superovulation is that particles or follicles are growing, and there is a follicle size distribution. They are not of same size, and that is controlled by hormone therapy. So the next particulate process, as a chemical engineer, we think about is crystallization. In crystallization also, you seed the crystals And essentially here I'm showing sugar solution dissolved in uh, dissolved in warm water, and if you actually put a thread in it and cool the water, you will see different sizes of crystals forming, and it is a time dependent process. So one of the things we tried to do is we tried to find analogy between batch crystallization in real practice and superovulation. And on the next, the diagram is showing is crystal size distribution, how it is changing with time. Initially, it is broad and it is actually shifting towards the right-hand side. Same thing happens, the size distribution shifts on the right-hand side, and the distribution becomes narrower in superovulation. In batch crystallization, in real practice, what they want is uniform crystals at the end of cycle. And in superovulation also, you want as many mature follicles as possible. So the follicles ranging from 18 to 22 mm, that means you also want uniform size particle. Given this analogy, we then actually develop model for growth of superovulation. I won't, is based on the follicle size distribution. When you think about distribution, you may have to divide it into bins, 0 to 4 mm, 4 to 8 mm, 8 to 12 mm, and you will see that at different days, the follicle sizes shift downwards. What we did is we had developed this model. It's a big model with differential equations for defining the distribution in terms of movements, and that's characteristics of distribution, as well as some of the growth term, which depends on the hormones. We actually, what we do is we customize the model for each patient by taking day one, 2-day data, the consecutive 2-day data. Many times it's the first day or and 5th day, or first day or 4th day when the session comes, and first day or 6th day, whatever the data we have, and we actually check follicle size distribution. We did this, and in the agonist protocol, we had 1 growth term. In antagonist, we had 2 growth terms. Growth before antagonist is given, growth after antagonist is given. What we are predicting both cases is follicle size distribution on day 11, and actually in case of antagonist, also day to start antagonist. Believe me, it's a lot of equations. What we did, a mathematical formulation. We also could formulate correlation between estrogen levels and the movement model that is related to distribution, and found that it is a function of third movement. So we can also predict estrogen levels with accuracy for most of the patient, more than 99%. Provided you provide 2-day estrogen level data. Many times when I looked at the patients in India, they don't do blood tests, so estrogen levels are not available. In that case, we don't predict estrogen level or use estrogen level. So what you do in the model is you organize the follicle size at 0 to 4, 4 to 8, 8 to 12, 12 to 16 beans, and put, showing that, okay, day 1, I had 4 follicles in 0 to 4 mm, 4 to 8 mm were 12, and then in day 5, how that is changing. We only take these 2 days data and predict what can happen our model, and these are some of the results. The dots are showing actually what is actually observed in a patient, and lines are our model, and you can see the model predictions are pretty good. In fact, for 95% of the patient, the model prediction error of the mature follicles is something like less than 5%. For the 5% of the patient where it's higher than 5%, it goes up, not more, but up to 10%. So that is still acceptable error. Given that we can predict, and this is what we did, is we tested it and did the analysis using retrospective patient, both from India and in United States, 150 patients, and we found these results. Given that we can actually predict what can happen, now we can even optimize the dosage. Now, our aim in optimization is that we want to obtain eggs or follicles in high number within a specific size range, 18 to 22 diameter. So what we are saying is we want uniform size follicles. So we want to minimize the variation in follicle size on day 11. And this is something called optimal control, a difficult problem in optimization. If you compare, optimal control has been used in engineering for a long time. All of you have traveled by plane sometime. So how the plane decides what path to take, what velocity to do is using optimal control. The aim of the plane is that reaching the destination in minimum amount of time. So we could mathematically write the objective, which is expressed here in words, and essentially use solve a difficult optimal control problem. Here I'm showing results of patient 1, what is happening. The optimal control side, the optimization results are shown in terms of both follicle size and FSH dosage. You will see the green dosage are optimal and the red dosage is what which the physicians use. We are tapering off the dosage and reducing dosage. While if you look at it here, you will get higher number of follicles in the bin which you wanted, and essentially this patient got 4 follicles, and with our model it will give you 6 follicles. We did a couple of simple trials earlier, clinical trials, and found that our results are consistent. Here is some of the statistical results. What we found that optimal mature follicles in experimental is in compared to experiment is that we are plotting a ratio. Most of the time is higher, and dosage reduction is something like 20 to 60%. Antagonists, you get more dosage reduction and higher optimal mature follicle with this approach. So the thing is that this has been tested, and so we did a systematic clinical trial last year, and the results are published. If you need a copy of that paper, you can go to www.opt-IVF.com. You will see that there is a link to the clinical trial paper. So I'm going to share this clinical trial was actually done with collaboration with Dr. Naina Patel from Akanksha Hospital, Anand. And it was really good that she agreed and she looked at the promise of the technology and we could do this trial. So now we have a software called Opt-IVF. You can actually visit www.opt-ivf.com. Again, www.opt-ivf.com. And we have actually implemented the software, which is, as I said, a lot of mathematical things are involved. And you can try out, you can register for use, giving your email and other information, and you activate the account, and then you can use it. If you have any difficulties, you can always reach us. Okay, there is a phone number given right now till end of February. I am available on WhatsApp. Currently, I am a visiting faculty in Indian Institute of Technology, so I will be available on the Indian number. So you can contact always and get information. We are giving 10 for patients free of charge, and we have decided the charge is very minimal for each patient, like after 10 patients, compared to what we, in fact, it is really, really less than 10% of what savings you will be getting by savings on your medication and testing. And I will show you the results of the clinical trial later. So first, let's say Opt-IVF. what do we do is we actually gave an option based on literature. You can calculate initial dose and the day 1 to day 4 using either AMH, FSH, and age, or AMH, AFC, and age. And you can decide that whatever data you give, and it gives the initial dose. Once you give initial dose up to 4 days, then you call the patient on the 5th day. You give this data, day 1 data, which is the base data before the dosage start. You give it in the bins 0 to 4 mm, 4 to 8, 8 to 12, 12 to 16, and so on. You also decide what kind of protocol you are using, agonist or antagonist, and you give the day 5 data. So what Opt-IVF will produce is the dosage day 5 onwards, and also the trigger day. Generally, what we have found, most of the patient, it says that you taper off the dosage. This is very important because what happens is that in general, doctors either keep the dosage constant or increase it. Rarely they taper off. What we found is by tapering off dosage, you are coming essentially arresting the growth of lead follicle and let other follicles grow. So that's why you can get more follicles. The other thing we observed is that this gives close to natural embryos. We get a lot of grade A embryos because of this. And you will see that in the clinical trial. So clinical trial results, we did 22 patients with Opt-IVF and 22 patients whatever doctor has done. And essentially we had normal PCOS and poor responders. In the test case, we had more PCOS and poor responders as compared to control cases. And we actually looked at total dosage, testing, how many mature follicles are resulting, how many M2s, and how many grade A embryos. Again, this trial was done with Akanksha Hospital, and Akanksha Hospital has been using Opt-IVF on a daily basis now. And Dr. Naina is a right contact person. You can contact her and check what her opinions are because she is using on a daily basis. We have a larger trial going on both with Akanksha Hospital and with Indira IVF. And the results are consistent with up till now with this kind of trial. So total dosage, you will see that we have listed here total dosage given for the test cases with Opt-IVF is significantly lower than control cases. Same thing you will observe with the poor case and poor control and PCOS patients also. Overall, obviously, and all of them are statistically significant, even if the number of patients are low. What we found that consistently we actually reduce dosage. The probability is for the t-test is less than 0.001. As long as it's less than 0.05, that is statistically significant result. We also reduce testing by 50 to 70%. What we found is that mature follicles, we actually get sometime less, sometime more, closer to the actual, but the difference, so that's why the difference was statistically not significant. If we do more patient, maybe there will be some statistically significant result. Same thing, M2s we get more, but again, the difference was not statistically significant. However, a surprise result was that we always get high number of grade A embryos with Opt-IVF as compared to normal practice. You will see that here the normal high quality embryos, we got 1.7 normal patient average, it was 4.5, poor 1.67, for control case ours was 3.25, and PCOS average was 3 and because stage was 7, everything is statistically consistent. We are getting high number of grade A embryos all the time. Dr. Naina Patel has done some of the test cases and she always present those, and most of the cases when they get grade A embryos, they also get pregnancies. One of the case I will talk about was she is a patient coming who did IVF cycle in the United States, 43-year-old patient, difficult patient. What Dr. Naina did, she came to Dr. Naina's hospital and she wanted to do a trial. She was giving dosage in United States, starting dose was 450 and increasing. And Opt-IVF said that no, start the dosage as 225 and decrease it to 187.5 as tapers off. So something like significantly lower dosage. So, and she got something like 3 to 4 grade A embryos. While in United States, they said all her embryos were overcooked. Her follicles were overcooked and they didn't get any grade A embryos. She wanted to try one more cycle with higher dosage because she was saying, how can that dosage be lower? She tried lower dosage and higher dosage, similar to what happened in the United States. They got 7 follicles, but none of the embryos were viable. So you can see the difference. You may get sometimes less number of follicles, but you always get very high quality embryos. So what we do is we actually, Opt-IVF specifies both initial dose and then it uses the consecutive 2-day data of follicles to get and hormones to give you dosage for the whole cycle. So you don't have to call the patient for ultrasound till the trigger day. It also tells you the trigger day, and what we found is that on an average 30 to 40% reduced dosage, higher number of grade A embryos, and significant reduction in testing. This work wouldn't have been possible with my collaborators. Dr. Vibha Bhalerao, Jizamata Hospital, Nanded, gave us the retrospective data and some early trials. Kirti Yanki was my PhD student, Apurva Nisar, PhD student, and Dr. Eli Hubaika gave us the retrospective data from United States. Dr. Naina Patel and Dr. Sanjay Zog helped me conduct the clinical trial. With this, I will then show you the Opt-IVF. We can do one patient. You can go to optivf.com. This is the software I have developed, and essentially you can see clinical trial paper. You can download here and as well as see the demo. You will have to sign up. So I have already signed up and I have username and password. Once I have that, I can start. I can start as a new cycle and essentially Opt-IVF saying, please save all the data, otherwise you will lose it. First, I had to give patient ID. Since the conference is in Ethiopia, I'm going to say Ethiopia 1, and I can go to initial dose. This is a patient, maybe 31 years old with AMH2 and AFC 15. I have this patient data, and you will see that it predicts 225 as FSH dose. I will you can decide the antagonist or agonist protocol. This was antagonist patient. And once that is happened, we have to give base follicle size distribution and dose. So the day 0 or day 1, the follicle sizes were 0 to 4 mm, but 10 and 4 to 8 mm were 3. The dosage was 225 as predicted, and you can overwrite that dosage if you want, and you can go The patient will come from second visit. You can use as a continuous cycle, but here I'm just giving the data of the second day. Cycle day 5, what is the follicle size? It changed 0 to 4 mm per 2, 4 to 8 mm per 8, and 8 to 12 per 3. That's about it. That's the data I have to go, and I can execute the program. You will see on the screen, it may be small now, but essentially it says antagonist start day 6, day 5 FSH is 225, day 6 225, day 7 225, day 225 9 187.5, and 10 187.5. No dose on trigger day, and trigger day is day 11. You can even download the report. The report gives more information. So you can actually download, it gives you what initial dose, how it is, what initial data you're given, and the dose, and the dosage profile, trigger day, and also how many follicles you're getting every day. So this is this thing, you can try it out, or you can go to next patient and so on. And as I said, that we are giving 10 patient free. So please try out for, I think for a month, this is valid. And the rest of the time, the cost is not that significant. You can try out patient, and if you have any difficulty, always contact me. With that, I'm going to sign out, and I'm going to put my first slide so you know how to contact me. So this is my email address, and on the website, visit Opt-IVF, Opt-IVF, not IVF, Opt-IVF, Opt-IVF.com. You actually will get phone numbers and things to contact. If you have any difficulty, you can always contact us on WhatsApp. Thank you very much, and I will answer any questions you have.
Good evening, everyone. So with this, I start my presentation that what was our clinical experience at Akanksha. We know that controlled ovarian stimulation is one of the major factors to achieve a desirable outcome in ART. And we also know that FSH and LH play a synergistic role in folliculogenesis when we stimulate the patient. And today there is no blanket protocol, or nobody can tell you that use this for all the patients, because each patient is different. We need to tailor each individual patient's protocol so that it maximizes the prospect of success and also minimizes the complication. So our aim should be to recruit a uniform cohort of follicles, prevent any premature LH surge with definitely 8 to 15, but in poor responder even 5, but good quality oocyte. It's the quality that matters the most, to avoid hyperstimulation with minimal injections, a good endometrial development, and we have enough embryos, and it should be cost effective and safe. And we now have ovulatory disorder classified into hypothalamic, which is genetic autoimmune iatrogenic neoplastic, pituitary, that is functional, infectious, inflammatory, trauma, and vascular. And type 3 is ovarian, which could be physiological, idiopathic, endocrine. And type 4 is PCOS. When you are evaluating a patient to decide the dosage, what will you look at? Age. Higher the age, you would like to give higher the dosage. With increased BMI, you want to increase the dosage. Definitely see the race and ethnicity. Maybe in Indian scenario, we need a higher dosage compared to our Caucasian counterpart. The cause of infertility, whether any surgery is done on the ovary, endometriosis, history of tuberculosis, all this should be looked into it. How many years of infertility, even the nutrition and health status, if we have a previous response, and what is the ovarian reserve and what ovarian response, and the basic hormonal profile. So in vitro fertilization, a successful outcome depends a lot on individualized controlled ovarian stimulation. We have to identify the patient first as the patient response, hyper, hypo, or normal. What type of gonadotropin and dosage we want to give, what type of agonist or antagonist protocol we want to give, how do we monitor the patient, how do we decide the timing of trigger and which trigger to use, and then if fresh ET we are performing, we find out that. So a broad ASHRAE guideline says that you have low responders, give 150 to 300, agonist, antagonist both. Normoresponder and agonist can be used, but with better is antagonist. And then 150 to 225, and high responder definitely only antagonist, and there the dosage should be low. This is a broad guideline that they have given. And accordingly, we classify our patient as high, normal, poor, reduced, and negligible. There's something new that has also come up, the FORT, where the small antral follicle can't reach the pre-ovulatory follicles. If it is less than 70, that is more 70% or more, it's normal responder. But you are seeing initially about 15 follicle as a basal antral, and only 3-4 reach to the level of pre-ovulatory 20-18 millimeter, means a hyporesponder. And FOI, that's the follicle oocyte index, where if you are seeing pre-ovulatory 10, you should at least get 7-8 follicles when you retrieve it. But if it's less than 50, that is called low FOI. Now, the protocols can be agonist, can be antagonist. And fixed antagonist is most of the doctors who prefer to go by. Even flexible is now increasing, where you start from day 2, day 5, or day 6 you call. Day 6 you start the antagonist. Up to day 10, 11, then give the trigger and retrieve. And when it is flexible, you wait for the follicle, one follicle at least to reach 14 mm, which could be day 6, day 7, day 5, and give the antagonist. And pre-treatment, we prefer either with estrogen or the norethisterone. And whether to add FSH, LH with the antagonist is again difficult. And when you see on day 6, how to decide the increasing and decreasing, whether we should coast or we should not coast. Monitoring is very important, and current is we do the ultrasound monitoring and do the hormone assays as and when needed. Now, why do we monitor a cycle? So that we have adequate response. It helps to decide when to give HCG and monitor any complications. With COVID, we know that we had minimized the visits of our patients to the hospital. And when the patient is undergoing IVF, the concern is how many visits will I need without compromising the cycle. They may be working, they may be at the job, and when they come to us, they have limited time. When it do the scan, do the blood test, advise the injections, then they rush back. So that is one very important thing, that the patients wants minimum visit without compromising the cycle. 2, we do not want to overdose or drug our patient on higher, because the side effects, if at all minimal, are there. So we want to do that also. And most importantly, get good quality eggs, and in return get good quality embryos. We don't want a surprise that we have given a beautiful stimulation, everything was fine, and we get just 2 eggs, or we get overcooked eggs, as the embryologist will say, it's not good, granulated with vacuoles, or we get a very, very GV type of eggs, like very small eggs, they have not matured, and most of them were GV or M1, there were no M2. And we want a synchronous cohort. We don't want one follicle to grow to 20 and the remaining lagging behind, and then you get just 1 egg or 2 eggs. So all this is very important. I started my IVF about 2.5 decades back, and that time it was agonist, and our deciding dosage was 225 fixed in mind, and then we change here and there a little bit, FSH and LH, and continue the same dose, with a tendency to increase the dose and not decrease. And even in the literature, they say it's not good to reduce the dose. You starve the oocytes, the quality of the oocytes will not be good. But that is what the reverse I saw here. And then I went into the depth of it and studied. And it is really important to reduce the dose. Maximum try to follow the natural physiology. And by reducing the dosage, you are trying to keep your FSH less than 20. We do not measure FSH during our stimulation, but it's very important. All throughout, we have to keep it less than 20. You can skip also a dose for 1 day without actually compromising the growth of the follicle. And here we are reducing or increasing in a very minimal dosage. So I'll talk of this patient. She was 41 years of age. Husband had severe OATS and her AMH was 1.7. On day 2, E2 was 30, progesterone was 0.375, FSH was 7.85, 1 IUI, 1 L plus H, and 1 IVF. I'm sure if such a patient comes up, first of all, the age, which is high, and 2, we would like to stimulate with the maximum dosage. So go ahead and give 450 of HMG or 225 HMG, 225 FSH, and then do the retrieval because we want to. But the point I'll tell you, when I entered it in the Opt-IVF, there were 8 to 12, 3 and 12 to 16, 3. Naturally, they get a dominant follicle earlier. We started with the dose suggested was 300. We started with 300 HMG. Then on day 5, 6, when the patient came, there were 8 to 12, 3 and 12 to 19, 3. Again, the dose suggested was reduced from 300, it came down to 225, add antagonist on day 6, 225 day 6, 7, 8. On day 9, it came down to 150, day 10, 150, and day 11 trigger. And this without calling the patient in between for a visit. So the dosage required was 2,475. Dual trigger was given on day 11. We retrieved eggs on 13, just 3 eggs were found. All 3 fertilized, even with a severe OATS sperm, which were occasional. All 3 A-grade embryos. We did a fresh ET in this patient because progesterone level, everything was normal. And in advanced age patients, with everything is normal and with a severe OATS, I do prefer to do a fresh transfer if they are not opting for PGTA. They were not opting for PGTA, fresh ET done, and a positive pregnancy. Normally, our dose would increase or remain the same. And as I said, before this, I would have thought of even starting with 450. Now I'm talking about a PCOS patient in this Opt-IVF, which I had included. On her first day of periods, her LH was 5.3, E2 56, progesterone 0.2, and her AMH was 8.05. She was 27 years of age. 0 to 4, 5, 4 to 8, there were 33 follicles, and 8 to 12 were 3. Opt-IVF entered and decided the dose of 225 for first 4 days. So we started with the 225. They've given the normogram if you wanted 1.2.5, but as I said, that Indian ethnicity and we were to freeze all the embryos, she also wanted a PGTA, so we went with 225. This was the data on day 1. Then, day 5, when I called her, we had 4 to 8, 18 follicles, 8 to 12, 23, and 12 to 16, 3. We entered into the Opt-IVF on day 5 and we got the data that start antagonist on day 5 and continue day 225 for 3 more days. Then 8th and 9th go for 187 and day 10 just go for 150. On day 11, you give the trigger. So the total dosage, if we continue 225, would have been higher. Here it is lower to at 2,100. And we retrieved 13 eggs. You will be surprised. Egg retrieval was on 13. 23 eggs we retrieved. 20 fertilized. And we got 14 blastocysts, all of 4 AA grade. And we did PGT. And in first cycle, she is pregnant. This patient is very interesting. She is 43 years of age. Her AMH 1.8, LH this, and previous history of 1 IVF in US where a very high dosage was used. And she had a negative cycle. She said, the doctor said my eggs were overcooked and not good. So when she came to me, I entered her data into the Opt-IVF. And 4 to 8, 9, 8 to 12, 0. And the dosage suggested was 225. She just could not believe. She said, I have got 300 IU morning, evening. Initially 450, 600. Doctor, are you sure you are going to get eggs? I said, yes, we should follow this. And we followed it. Then when she came on day 5, 4 to 8, there were 3, 8 to 12, 4, and 12 to 16, 2 follicles. And the dosage, when I entered into the Opt-IVF, further reduced to 187.5. with antagonist on day 5. She was asking me again and again that I continued the same dosage. I, in fact, increased the dosage towards the end. And how are you reducing? I said, no, I'll follow this. And because she wanted to do a duostim to maximize the number of eggs we got, we gave the trigger of decapeptyl agonist. And day 9 trigger was given. The dosage used was just 1650. And on day 11, we picked up only 3 eggs. 2 were mature, M2, 1 was immature, but we got 1 blastocyst. And we said the quality of egg was very good. They were not over matured, overcooked, and we have got a brilliant blastocyst. She never got a blastocyst out there. PGTA was done. And then 4 days later, a second stimulation, duostim, was started, where the 4 to 8, 9 follicles were there, 225 started. Again on day 5, 4 to 8, 2, 8 to 12, 2. The dosage suggested was 225, 225, 225. On the 7th day, we added the antagonist, day 5, but 7th day again, it was added. And we continued this with 187.1. In duostim, the second stimulation is normally longer by 2 days. So on day 13, we gave the trigger. On the 9th day, we were seeing these follicles. 2288 was the dosage required. Egg retrieval done. 4 eggs, all 4 matured, 2 blastocysts at day 5, out of which 1 was euploid blastocyst at 43 years of age. So, in my opinion, if I had continued that patient, and then interesting thing was, she's saying that, doctor, you're retrieving just 3 and 4 eggs. In US, I used to get about 7, 9, 11 eggs. So why am I getting less eggs? The 3rd cycle you try with my dosage, which I used to use over there, the highest possible. Maybe I'll get more eggs and more blastocysts. And then after giving her a break for 1 month, I did follow the same protocol. We got 7 eggs, 3 fertilized, C-grade embryos, and none reached blastocyst. So you can imagine the quality of the oocyte. And then she agreed that I wish I had started a lower dosage again rather than going for the higher, and I had decreased the dosage. So this is important. Even I could not digest initially that how this is happening. But once I started using it, I'm so happy with it that the previous things that you can't reduce the dose, reduce or coasting is bad, you continue the same, the eggs can get starved, it is the quality. Maybe you get 1 or 2 less or 1 or 2 more, that does not matter. But by giving 12 eggs which are granulated and a C-grade embryo not reaching blastocyst is not good. Rather than that, you give eggs which are, as by the chemistry and mathematical, like a little bit of artificial intelligence introduced here, which is going to be good for that patient profile because we are considering so many parameters. So controlled ovarian stimulation should be individualized. All the new beginner doctors would be very confused about what is the starting dose, when should I add antagonist. And sometimes I've seen when I've used Opt-IVF that the sizes of the follicles are on day 5 are small. We would generally try to increase the dose, seeing that all of them are 9, 10, 11, 9, 10, 11. Why not increase the dose so they grow faster? But Opt-IVF will tell you to reduce the dose. And even I'll be puzzled. Will I be compromising this cycle? No. But after 2 days when you call the patient, the follicles have nicely grown. So the requirement of that extra hormone was not there which you were giving, and that was compromising the quality of the egg. Changing the dose, it gives a very good advice without even thinking deep into it. I would say you can be that rest assured, and retrieval of the eggs, the number of visits less, dosage less, quality is definitely improving. And there is somebody who is following in this world the same protocol where they are trying to follow the cycle naturally rather than increasing, because we all know that FSH goes down once we are starting stimulating from day 7, day 8 and day 9, and only LH comes into the picture. Here we are pushing a higher dosage all throughout. So maybe we are compromising that egg quality. So this is a great boon and support for new IVF specialists. There is any kind of confusion when you to start antagonist or when to give trigger, 1 day less, 1 day more, deciding the ideal dosage. And at the same time, supposing in one patient you have burnt your finger and not got a good end result, this is going to help you guide the correct way how to stimulate and how to control the gonadotrophin dosage and when to do the egg retrieval. So customized, individualized ovarian stimulation is the right way for the best outcome. It is definitely an art, and Opt-IVF can help you get the best outcome for your patients. Thank you.
Thank you so much, Dr. Urmila, and thank you so much, Dr. Nana, for this insightful presentation and sharing all the details about Opt-IVF. So I hope everybody enjoyed the session and they learned about it. And with that, I can see in the Q&A window there is one question. Can you please give Opt-IVF protocol screenshot, as I missed that part?
Okay.